So we've had a lot of sessions so far today, and yet looking at spiritual care. So pharmacists, um, physicians, we all developing competencies for spiritual care. But there is a tension in medicine between caring for the body and caring for the whole person. So if you're spiritual and not religious, you have some particular struggles. No, there's less accountability with other persons, less benchmarks for discerning truth. If you are religious and not so spiritual, you oftentimes just provide spiritual care for other people that are just like you. And if someone presents to you a different modality of faith, let's say you're Christian and they're Muslim or Hindu, you don't know how to approach it, so you don't offer spiritual care. So when we carry over the medical model to spiritual care, we have some problems. So generally, when you look at competencies in spiritual, in any other part of your discipline, if you have knowledge, like you were discovering, and you have confidence in providing that type of care, you generally are thought of to have competency. But that does not hold for spiritual care. It's a more complex skill development. And I'm going to look at what has been missing in our competencies, our understanding of competencies. So generally, we focus on some tasks, and physicians are particularly strong in these tasks. So they like to focus on spiritual assessment, a task, and they like to look at how to provide interventions. And so there's some those are good skills, but that's not the whole picture. So when we focus on tasks, we become automated in the care we give. So we tend to provide the same type of care to a variety of patients. And that's not always going to meet the spiritual needs of people. So here we have Jean Watson, just as she is a caring theorist. She lives in Colorado right now. She's 85 years old, and she is still going strong. And so I've had individual session with her. She is adamant that her care theory prepares everyone for providing spiritual care. But there's some interesting research that is showing. Now here we have her model and diagram. So when you look at that wheel of spiritual care, there's a lot of spiritual themes in it, is there not? There's loving kindness, caring for the soul. Those are a lot of spiritually oriented themes. But what does the research show? It shows by Harrod, it's not even a new study, 2019, nurses, even though they're trained in this lens of caring theory, they still don't have confidence and skills in providing spiritual care. So what is missing? That's the burning thought that drew on my study. So what I did is I want to understand the different types of training to help facilitate competency in spiritual care, because it is a more complex skill than other skills in medicine. It requires not just understanding and positive attitudes, but there's still something missing because providers are not providing. So I wanted to bring to light what is the process. Now, what we haven't talked about in this session is that spirituality grows in phases. It matures, just like moral development, like cognitive development. If you look at a 2-year-old, they are very concrete, then they become rule-based, and then as you move into adolescence and later, you become able to handle abstractions. And so it's the same with moral development, and if you've heard anything about spiritual development develops in the same way. And we can get stuck and become automated in the spiritual care we provide. So if you look at people and you listen for spiritual themes, what you want to do is move towards their story, their life narrative, and learn how to recognize spiritual themes and what they tell you about their lives. And so you're going to hear a variety of things. If they're early in their faith development, you'll hear things that are very concrete and rule-based. And then you might hear themes that are around community-based belonging. And it's not until if people keep maturing, you'll hear their spirituality becomes more abstract and more abstract. So you'll see that development. And so that's the same thing that has to develop in the practitioner. You start off by following protocols, you know, what's the fact or what is the hope spiritual assessment protocol, and you need to continue to reflect and grow. So what I did is I did a narrative review, and I used peer review sources like PubMed, Science Direct, Sage, NIH, ResearchGate, and I looked principally at articles between 2020 and 2026, and I used some seminal resources. I hope that you look at my resources. There is a very, very interesting resource from 1973 looking at the development of maturation in altruistic spiritual care. It's my only 1973 resource in my resources. And the key words that I used were spiritual care nursing, interprofessional spiritual care, spirituality, spiritual distress, a new topic called spiritual leadership. And that is coming from nursing literature, looking at how do we take healthcare providers that are altruistic, that are empathetic, and how do we help engage them with the healthcare system so they give beyond what they have to give? It's because we all give more than we have to give if we're giving good care. And I deduced it down to 10 peer-reviewed studies. I used a variety of types, qualitative, quantitative studies, and looked at some commentaries, and I applied them into a matrix to look at the factors that would facilitate this further maturation of our capacity to offer spiritual care. And it was very interesting. So what did I find? That yes, the EPIC project has developed some good, sound, the 4 principles of intraprofessional spiritual care, interprofessional spiritual care, spiritual assessment, and spiritual interventions. Those are all good competencies. So what has gotten in the way? They have used good methods. Self-reflection on your own experiences is very powerful. Having positive attitudes is very powerful. But if we look at things in a linear manner, we miss the whole boat. That's why I included a variety of types of studies and commentaries. Just as the speaker this morning was talking about, we can miss the baby in the bathwater, as we say in America. We can miss the key factors if we use the scientific model too rigidly. We need to open our lens. And so I like to use more of a 3-dimensional model of formation so that we can capture the whole dynamic picture. So this is one of the most interesting studies. Rhonda Massio out of Australia has done 2 studies, and you'll find them in my resources. What they found, it's very interesting. We show the maturation of spiritual care skills from Model A to Model D. So Model A nurses, I'm talking about nurses here, they tend to be more, they learn a method, they follow a protocol, they apply a spiritual assessment, and they give the same type of care to everybody. They're very directional in their care of other people. But they have limited emotional connection. Okay? So they feel like they develop a model of providing spiritual care that follows the protocol, checks all the boxes in the medical record, but they do not relate emotionally to the patient, and they manage the show. But as people mature and they apply spiritual care skills, they realize Model B. So they want to develop more of an emotional connection to people. So they help facilitate an emotional connection to the patient, help facilitate them getting care from their ministers, so to speak. But it's hopefully they continue to grow in what we call an attunement model. They become able to be in sync with the person that they care for. So Model C. And if you continue to grow, she saw that we develop in Model D a strong emotional connection to the patient. We move back, we're not directional with the patient, that we help facilitate their agency. So you can see that it's a much more complicated, more complex model. And what causes this maturation? What often happens with practitioners, physicians, nurses, dietitians, everyone, unless they reflect, they stay in model A and B, and they feel so good. They get this method of providing spiritual care down. They feel so good. They pat themselves on the back. I really know what I'm doing. I'm so confident. If they take the spiritual assessment that Tove was talking about, the epic self-assessment, they score super high because they really know what they're doing. But patients don't feel their care. So what I was looking for is what promotes this progressive maturation. And it was very interesting. It is the very element that we get into healthcare to provide. It's that empathetic connection with patients. It creates caregiver distress. And that is a very good thing. Let me show you why. So my modeling is a little bit off here with my headlines. I'm sorry. So I just summarized this. Model A nurses they follow the protocols, they use the assessments, and the problem is it helps them maintain their ego. They feel very competent. But what is required for competent spiritual care is what we call ego transcendence. We have to learn how to let our own needs, we need to be aware of our own needs, but we need to be able to offer that care that's over and above our own ego. Because we could get stuck in just doing the same thing with everybody because we feel good about doing it. So what we want to do is, what is going to push somebody towards Model D? It's their own experience of suffering and distress. Now, we're not going to cause suffering for ourselves, but in caring for people, we experience an empathetic pain in working with them, oftentimes. So if we can teach people to reflect on their own suffering, that can be the force that nudges them into Model D, into true competency in providing care. So there is an assessment by Vanderweel. I hope that you look it up. I have a slide here in a second. There are 7 questions on the personal suffering assessment that are really helpful, that would help you get in touch with how much your own suffering is in operation in your life right now. And in healthcare, we try to minimize suffering, but we need to engage it in our own selves, in our own lives, because it's something we cannot control. And that's the very movement that helps us be competent to engage the care that we offer in a way that we experience distress and suffering, but we reflect on it, and it promotes us to be more altruistic. Does that make sense? That it's the very letting go of our own ego needs that helps us mature. So what is suffering? Pain and suffering can be different. So we all have different pain thresholds and suffering. So suffering is the privation of complete human well-being somehow. That suffering can involve physical pain, but it's really the unknown essence of suffering that causes distress. And we want to harvest that focus so that it can be an adaptive function to help us grow. Suffering helps us come to a deeper awareness and understanding of our own personhood. So this is an example of the 7 questions from Vanderweel. You might want to take a photo of this. It's a suffering assessment scale, and you could use it on yourself. You could incorporate these. Spiritual assessments are only helpful if we can incorporate them and use them in our thinking to understand what we're hearing in our patient's story. So we want to rate these. On question 1, 0 to 10, to what extent are you suffering right now? How would you rate it? And then 2 to 7, we rate our agreement. So the intensity of what I've been experiencing feels intolerable. The length of time I've been suffering or expect to suffer feels intolerable. And you go through, and this gives you an assessment of how much you're suffering or how much the person is suffering that you're working with. And it helps us. We want to harvest our own movements of suffering that we can't have because it propels us. So we need an animating dynamism. So we want to move our understanding from checklists and linear competencies to helping us know how we personally engage and care for people. And so it's a transformative shift. So engaging the adversity that comes to us is really like a kinetic transformation in your own capacity to care for people. So here's the model. All along, we've been looking at spiritual care competencies and writing about them for the last 20 years as their linear competencies, their checklists. And we use some good methods of self-reflection and mentoring and developing positive attitudes, but it is not enough. We need to know how to engage it dynamically by engaging our own personal reaction to the people we care for. And that creates a gear there, a three-dimensional process of formation that promotes the change in our hearts, our maturation of our skills. Isn't that an interesting diagram? That we move from linear understanding and confidence is not enough, but being able to engage and being available and attuned to our patients. We want to mature. So that's just about it. So the implications are we want to move from a linear competency model. We want to cultivate a three-dimensional model of caring for the human person that emphasizes altruistic giving on our part. And we can develop that capacity by learning, by positive attitudes, and by engaging peers. In Colorado, I provide spiritual care training to healthcare professionals. I have some online, anytime, anywhere courses, and I have an online interactive training process to help support practitioners in walking this journey of reflecting. It's been beautiful to do. So we need more research to look at the integrative skills of spiritual care. So, and what our goal is to move from ego maintenance to being able to be transformed and being transcending of our own needs. Not lose sight of them, but just that we be able to engage them differently so that we don't do care that just makes us feel good, but actually meets the need. Might be it. So limitations, there's an overkill in different discussions of competence. But there's been real minimal research on this dynamic engagement of the spiritual care competencies and what does it take to mature in spiritual care competencies. And a few transformative studies on looking at how to cultivate professional awareness. So in developing my training process, I drew on my training as a healthcare chaplain that helped then oriented toward. So feel free to contact me. I wrote a book, a short book. So there's my Anytime, Anywhere courses and the 8-week small group interactive experiences. I wondered if, and here are my references, I wondered if we have time later, we could reflect on some of these questions. If you think of a time in your own formation when an experience rather than a textbook completely shifted how you viewed your role as a healer. And another one is, what's been the missing link in that moment that transformed your practice? You know, maybe does a patient come to mind that you engaged with in your care that really transformed how you move forward from that experience? those are my thoughts. Do you have questions?